I'm going to talk to you about the PFN, proximal femoral nail, Intertan nail, in a comminuted intertrochanteric fracture of femur in 81 years old patient. I am Professor Dr. Dilip Shah, attached to Pfn Intertan Hospital. I have been a professor in orthopedics and I have teaching experience of more than 38 years. I have been winner of Secord Fellowship to Italy in 1985. I have been winner of AO Fellowship in 1995 to West Germany, winner of Bombay Orthopedic Society Fellowship in 1989. I have been an honorary orthopedic surgeon in Nair Hospital, Bridge Candy, and many other hospitals like Saifi and Nanavati hospitals of Mumbai. I have been an instructor for AO courses since 1985. I am recognized professor in the University of Mumbai and I have been examiner for postgraduate exams for MS as well as for diploma in orthopedics. I am recognized inspector to recognize hospitals for postgraduate training. I have been editor-in-chief of ASOR and I have been editor in many other journals. I am attached to many orthopedic organizations in various capacity as an organizer of conferences, chairman, speaker, and for many conferences in national as well as international levels. And I am also one of the coordinators who coordinates more than 48 cities of India with AAOS on Saturday evening conferences, which is from Chicago, Rosemont. This patient about whom I am going to talk to you is 81 years old and as you can see he has comminuted fracture of left femur which is very visualized. Now it's very difficult to decide what you are going to do. So I preferred to do an Intertan, which is a proximal femoral nail, and patient supine on fracture table and contralateral limb in lithotomy position. An incision of around 6 centimeters, I take it over the greater trochanter and go proximally. I prefer little longish incision so that you can see the point of entry pretty well. Once you have dissected out from skin to subcutaneous tissue, it's very imperative that you put the guide wire 4 degrees going from lateral to medial as compared to the anatomical axis. So with this system, you can open up and go into the center of the greater trochanter and head it towards the distal part going, if at all medially it's accepted, and start going down. At the same time, check it out on the lateral plane whether it's in dead center, and once it is confirmed or you need to change, then use the honeycomb whereby you can have adjustment of 1 to 3 millimeters anterior, posterior, medial or lateral, which you can visualize right now with the honeycomb. I am trying to enter more lateral into the canal and it's absolutely in dead center. So this is the honeycomb which gives you a good adjustment. Once you have decided, you have gone ahead and then push your guide wire down. If it's hitting the medial cortex, it's fine. Then with an awl, you can go down and you interchange it with a guide wire. Once you push in the guide wire, I prefer to go right up to the condyles. Once this has been done, check it out on the lateral C-arm images also. You ream the proximal end with the reamer so that there is no problem and there is always a stopper. So once you reach up to that point, you just automatically will stop and check it out on your image intensifier films whether you are at the right level. After that, you just start pushing the nail. You can choose the nail of various sizes, but then your nail should be seated in such a way that you make an angle of 135 degrees where there is a slot for the screws for the femoral head and neck. Make sure that it is absolutely abutting against the lateral cortex. Try and advance your guide wire in such a way that it is going the superior screw, which is a canceller screw, in dead center in AP as well as lateral. Once you have confirmed that, you can proceed and then you can find out the length Say for example you have got 110, so we expect 10 millimeters of compression. So we will be using a combination of 100 and 95. Drill for the distal screw, which is going to be a compression screw, and go up to the depth maybe around 5 millimeters less than the superior one. You have to go right up to the subchondral bone so that your screw also can go very nicely over there. So you plug with the L-shaped protector and then you drill in such a way that the slot in your drill is adjusted for the distal screw. Start going inside and just leave subchondraly. Once you have gone there, now you can see the compression which is happening by compression screw, and the fracture site is almost eliminated. Don't try to over compress. Very important aspect is when you are doing compression, the traction should be released and the limb should be free so that you can shake it also if you want up and down and make sure that it has been eliminated. We can lock these screws by using a special device which will not allow any further collapse. Once you have done that, then what you need to do is select either static or a dynamic depending on how much compression you have achieved. If you have achieved very stable situation, then you can use a static screw. Drill for that and measure the length. Maybe you can have 2 millimeters longer than that in porotic bones. Check it out that you have pierced the opposite cortex and the screw head is just near the lateral cortex. This is the immediate post-op what we can see on lateral aspect. You can see the head and neck, the fracture site is totally eliminated. This is the distal screw which is crossing both the cortices and the head and neck, which is showing a very good compression as well as sitting pretty well. The final lateral X-ray is showing a wonderful situation, and AP which shows that the fracture has been really fixed pretty well. This is the third post-operative day when the patient is lifting up the leg and he is walking partial weight bearing, but this patient is almost weight bearing 50 to 60%. This is the advantage that you got the stability on table, and this is the advantage that you have space which is only occupying in the center, not up and down like other PFNs. This is a stable fixation, and the distal clothespin will allow the nail to expand. And this is a wonderful system, and maybe if you start using it more and more, you will love it. I thank you very much for visualizing this video. If at all there are any questions, you can put forward to me. I am willing to answer. My email ID will be following soon.